All right, we do have a lot of questions. We are a little short on time, but I'll get to a couple of them. And just as a reminder before lunch, if you do have more questions, feel free to find the speakers afterwards. A lot of the questions actually have to do with HSV and VZV, and I think this is a concerning problem for all of us and obviously very prevalent. For both Dr. Tooley and Dr. Lin, there are some questions asking for clarification in terms of thoughts on Valtrex versus acyclovir, and thoughts on dosing for the two different diseases.
Acyclovir versus valcyclovir. Valcyclovir does get absorbed better into the body, so it would give you higher doses in your body. It does get metabolized through the liver, so you have to be much more careful compared to acyclovir, which you only have to worry about kidney toxicity. So you have to weigh those risks and benefits. It's also more expensive than acyclovir. As far as the doses go, for zoster, rule of thumb is double the dose of simplex. So for simplex, if you're treating an active infection, it'll be 400 5 times a day for acyclovir, or 500 3 times a day for valcyclovir, 250 3 times a day for famciclovir, and then just double that for zoster. For preventive, you use 400 BID for acyclovir, 500 once a day for valcyclovir, and 250 once a day for famvir. Anything different you do?
I completely agree, and I think that sometimes it can be confusing to kind of remember all of the different dosages. I think that double the dose is a good rule of thumb. We have had cases of HSV keratitis being resistant to the antivirals, and so that's potentially one reason to consider just using the higher dose right off the bat. So, and they're very well tolerated, so I think it's a very good approach.
What do you guys find to be the role of some of the newer topical antivirals for these patients?
Again, with HSV, definitely has a huge role to play. So you can use either oral or topical. They're thought to be equivocal. And so just remember, though, that topical medications, just by the way they work, they inhibit the DNA polymerase, and so they are toxic to your natural tissues too. So they're toxic just because of their preservatives, but they're also toxic to tissue. So remember that. And then for HZV, usually only for the initial 3 to 4 weeks, if you suspect it's live virus in the cornea, you would treat with topical antivirals, but after that, there's really no role. For prophylaxis, no role for topical. You only want to treat with oral because you want to prevent recurrences in the trigeminal and not in the eye.
Yeah, and I think just because the orals are very well tolerated, and perhaps because I trained at Proctor, there is a preference for the oral antivirals. The other thing that we sometimes do is add ganciclovir ointment for cases that are not responsive to the regular conventional treatment.
Great. I do want to continue with one more question for Dr. Tooley, which is about the Shingrix vaccine and sort of the timing of that in patients who have had zoster, and also do you modify anything if the patients have had prior grafts?
So for zoster, yeah, that's a tough question. So do you use the vaccine if they've already had? So if they've had shingles anywhere else in the body, I don't care. Get the Shingrix vaccine. But if they've had it in their eye and their cornea was involved, you know that they've got viral DNA sitting in their cornea. So there is potentially the chance that if you boost their immune system by giving them the vaccine, that's going to reactivate their immune response against the DNA that's sitting in their cornea. So there is a higher risk of reactivating the cornea, and I've had a number of patients who've done that. So I'm a little careful. I usually tell people that if they've just had shingles, that they really have immunized themselves, so they can probably wait a few years to let things calm down before they get the vaccine. And again, maybe right or wrong, but I feel like their CMI is up. If they do need to get the vaccine, and they are on topical steroids, I'll increase their topical steroid dose a little bit at the time of the vaccination just to prevent them. I've still had at least one patient who reactivated and rejected their transplant after they got the Shingrix vaccine. So I'm very careful when I'm dealing with patients who have zoster in their eye, especially if they've had a vaccine, a transplant, bumping up their steroid tremendously.
Great. A couple of questions here on steroid use. Dr. Rose Nussbaumer, they were asking sort of when do you time the start of steroid use? Do you always restrict it to after 48 hours? Do you start it earlier? And then are you only using Pred-Phos like in the SCUT, or do you use some of the other steroids as well?
Yeah, so for me, I'm very careful to use steroids only in culture-positive bacterial keratitis. So I want to make sure they don't have any other infections like fungal keratitis or acanthamoeba, because steroids are known to be bad in those situations. So culture positivity is really important. I don't use it for any atypicals. So SCUT definitely showed that nocardia ulcers did worse with steroids. And I kind of take that as a general indicator that atypical bacteria in general, we should not use steroids for them. I use Pred-Forte or dexamethasone starting at 48 hours. One of the things we're going to test in SCUT2 is whether starting at 24 hours is actually better, because there was a suggestion that starting steroids sooner was better. But because it hasn't been well studied, I do follow SCUT and do 48 hours. Does that answer all of the questions?
I think so, yeah. I think that's great. And then let's talk about steroids in the context of acanthamoeba and fungal, particularly if, I think, Elmer, you brought up the use of steroids at some point. When do you decide to put on a steroid for acanthamoeba? And then if you're doing a transplant, for instance, on a fungal patient, do you ever, what's your thought on steroids after those?
Oh, after fungal?
Or no, for acanthamoeba, because you brought it up yourself in your talk.
Oh, yeah, no, so did I say that? So for steroids, generally, I try to avoid them if at all possible. And the only indications would be once they're really deep into their treatment and we feel like we have some control. Sometimes it's pain, sometimes it's for the extracorneal manifestations. And they don't need a lot. I mean, if you're using topical steroids, usually 2 to 3 times a day at most is what you'll need to at least control their corneal disease. Scleritis is another issue that may require systemics. As far as transplantation is concerned, it kind of depends. I always teach our fellows that you have to examine the eye and see exactly how much inflammation there is, because you can do a transplant. If the eye is just fulminantly inflamed, they're going to lose the eye from the inflammation. You have to make a tough choice at that point to either use steroids or not use steroids. So, I mean, you want to give the eye a chance. If there's a recurrence, there's a recurrence. But if the inflammation is just going to eat up the eye, whether it be fungal, acanthamoebal, or bacterial, you've got to treat that and at least give them a chance to make it through the post-op period.
Dr. Sharma, any other thoughts?
So in case of fungal keratitis, if you're doing a corneal transplant for fungal infection, then I would like to withhold the steroids for a couple of weeks and start them after 2 weeks, provided there's no recurrence and provided the epithelialization has occurred.
Great. I think in the interest of time, we've already run over a little bit, so I want you guys to get to lunch. Thank you to all my panelists for the great discussions and the great talks, and we will see you guys back after lunch at 1:26 p.m. on the dot.